At the same time, sustaining the release, lowering the frequency of dosing, will also minimize the side effects, which also encourage the compliance of the patient to the medication. The mechanism of action of etopride hydrochloride, it increases the acetylcholine concentration by inhibiting the dopamine P2 receptors and acetylcholinesterase. Higher acetylcholine increases the GI peristalsis, increases the whole lower esophageal sphincter pressure, stimulates gastric motility, accelerates gastric time, and improves gastrointestinal coordination. It has also an anti-emetic action based on its dopamine B2 receptor metabolism. Its biological half-life is 5 hours, therefore it is a good candidate for sustaining its release. The uses of this drug, it is used in non-ulcer type dyspepsia, gastroesophageal reflux disease, gastritis in general, diabetic gastroparesis, delayed gastric emptying due to vagus nerve damage in diabetes, and also functional dyspepsia. The objective, as I said, the sustained release formulation in general gives a better compliance for the patient, and of course this may lead to more successful medication compared to immediate release medication. The justification, of course, the direct compression technique is a simple one compared to dry granulation or wet granulation, because it has economical advantage in terms of saving time and personnel, and also it improves the chemical and the physical stability. There is no moisture, there is no wet granulation, so the moisture factor is excluded. At the same time, even the dry granulation, during the dry granulation, heat may evolve, and if the compound is heat sensitive, it may degrade during roller compaction or other steps of dry granulation. And of course, the direct compression method is simple, and you are lucky if your drug is compressible and the dose is small enough to add excipients, direct compression excipients. If you have room for direct compression excipient, then you are likely to make direct compression rather than wet or dry granulation. Matrix tablets. Matrix tablets, all of you know matrix tablets. They are not favorable dosage form, of course, because the probability of failure of release. We have two problems in sustaining the effect of drug, the formulation. One is the dose dumping, and the other is the failure of release. So the dose dumping in matrix tablets is rare. If you have other formulation like granulation or sustained release granulation or microcapsules or microspheres or pellets, then it is very probable that the dose be dumped. So this may lead to toxicity and very bad side effects. In matrix tablets, this probability is very small, and the dose dumping is this is an advantage of matrix tablets. They are easy to fabricate, compared also to microcapsules or pellets or other forms of sustained release. But unfortunately, the failure of release in matrix tablets is the most probable thing. So the tablet may go to the small intestine and passes to the stools without releasing the desired amount of the drug. And this problem, of course, can be solved simply by adding a disintegrant. So you can add a disintegrant, super disintegrant, like executable or very strong starch. This is the tablet, but in this case, you you have also to be cautious about if the products of disintegration are still sustaining or not. So the matrix tablet itself is preferably be disintegrated into the solution medium. This disintegration into the solution medium will give you more than one advantage. First, you avoid the release failure in the GIT. Second is the hydrodynamic condition of the gastrointestinal tract. The hydrodynamic situation in the gastrointestinal tract. If you take this matrix tablet on an filled stomach, then it will take long time to go to the small intestine. But if it disintegrates in the stomach, then it will be released with food stepwise through the sphincter between the stomach and the intestine, because large tablet cannot pass to the small intestine from the stomach unless it is disintegrated to small particles about 10 micrometers or less to pass from the stomach to the intestine. The whole tablet cannot go through the sphincter unless the stomach is in the housekeeping phase. The housekeeping phase, the fast stomach, the fast state. When the stomach is empty, then the entire time takes from 90 to 120 minutes. And then it will open, and housekeeping phase, the tablet will go during this phase, because the sphincter is open and it goes to the small intestine. However, if you are successful to disintegrate this sustained release tablet and at the same time keep the sustainability of the drug, then you manage to make much better controlled release medication. From the experimental, we have studied first the drug excipient compatibility. First, in the formulation, this step is very important to make compatibility study between the excipients and the drug. We have used differential scanning calorimetry and IR spectroscopy to study all the interaction of the excipients with the drug. Really, we didn't find any change in the infrared spectroscopy. There is no effect of the drug with the excipients, and there is no also effect of the excipients on the drug. So the spectrum is the same. After mixing the drug and making the IR procedure, there is no change in the spectrum of either the drug or the excipient. But in case of DSC, we have found change in the endothermic peak for two excipients, lactose and ethyl cellulose. And this was exhibited as this is the formulation of 75 milligram metoprolite and metoprolite tablets prepared using hydrophilic polymers. We have a formula for hydrophilic polymers, sodium carboxymethyl cellulose, hydroxypropyl methyl cellulose, and of course direct compression vehicle ABC and starch. This is the formula for hydrophilic polymers. And this is the formula for hydrajets, methyl methacrylate polymers, hydrophobic polymers. They are not so water soluble. This is also the formula. We will speak in detail about this. And this is blends of the polymers, hydrophilic polymers and the hydrophobic polymers. And the in vitro dissolution study was made lower Cl, and then we shift the pH after 2 hours to 6.8, the stomach pH, the intestine pH, to see the whole spectrum of the solution, or the whole profile of the solution. The results, as I have said, this is the DSC spectrum of the drug. The first one, A, is the drug, ketopride hydrochloride, and B is the excipient, in this case lactose alone, and the mixture. You see that broadening of the peak took place, and also for both broadening of the peak and shifting of the melting point to lower melting point of the drug. This means that there is some interaction. There is some interaction between the drug and lactose, and therefore lactose should be excluded, because this, and at the same time, one may ask why the IR doesn't show any change. The IR doesn't show any change because there is no heat. But here in DC, we have heated the drug mixture, the drug excipient mixture, up to 300 degrees Celsius, and this causes interaction. This is a type of forced stability, in situ forced stability study. If we heat this mixture, one-to-one mixture from the drug and excipient to this high degree, then this will lead to some sort of eutectic mixture, and lowering of the melting point takes place, and also broadening of the endothermic peak and change in the enthalpy. This indicates the probability of the interaction between the drug and excipient at exaggerated conditions, means a sort of forced stability study. And this is normally made to show if there is a probability of interaction between the drug and excipient or not. And of course, if the probability exists, then we have to exclude this excipient and work with other excipients. All the excipients have been found compatible with the drug, except anhydrous lactose and ethyl cellulose. This is the DSC thermograms with ethyl cellulose. The same happens, broadening of the peak and lowering of the melting point of the drug. And this is an enthalpy change. This is the temperature change. The melting point of the drug is originally 197, and then it is lowered to 181 with anhydrous lactose, and then 174 with ethyl cellulose. And also the enthalpy change in grams per joule are lowered because of the presence of the excipients. This is a summary of the results with the hydrophilic polymers. The T50, time for 50% to be released of the drug, and time for 90% to be released of the drug in hydrophilic polymers. This is the drug hydroxypropyl diacylcellulose 1, 2, 3, and the drug alone. The drug alone, of course, is very short duration of release, 0.75 hour, and then the time with the HPLC 1 to 3 have been for the T50 5 hours, and then for the T90% means time for 90% of the drug to be released was 11 hours, and then the sodium hydroxypropyl cellulose have elongated the release, but for lesser extent. And methyl cellulose also have affected the release, but also to a lower extent. The difference between the hydrophilic polymers in the behavior is due to the density or the viscosity of the polymer in the acid medium, mainly in the acid medium. these cellulosic polymers are very affected by the pH. Their viscosity is decreased enormously in pH, in low pH. So the hydroxypropyl methyl cellulose is a good sustaining polymer, and it gives the 90% is 11 hours, means it goes to 12 hours. The 100% may be 12 hours sustaining the release.
Excuse me, Dr. Sayed. Doctor, I'm here. But we're running out of time. If you can summarize. Yes, I'm sorry for that. If you could just,
okay,
five more minutes.
I try in 5 minutes.
Oh, thank you.
These hydrophobic polymers, besides release, they are less effective in sustaining the release compared to hydrophilic polymers. And this is the blend of polymers. We have blended both hydrophilic polymers and hydrophobic polymers, and we have reached a good situation. The effect is promising, especially in the HPMC RSPM. This RSPM is of low permeability, very low permeability. Therefore, affects the release. Okay? These are the profiles, and all of them almost the same, but the drug alone is very soluble. It's a soluble drug, and therefore the effect is very pronounced if you compare the drug alone with any of the polymers. And this also has a hydrophobic polymer, and this is the hydrophobic polymer, and this is the hydrophobic polymers alone. They didn't affect the skin. The balance of the dose has been released in the pH 1.2, and then these also are the other hydrophobic polymers. They also release the drug majorly in the pH, acidic pH side. Okay, this is almost the polymer blends. The polymer blends have sustained the release. Pronouncedly, and we have chosen this formula to proceed and to make in the future, bioavailability and measure the concentration of the drug in the plasma using these optimized release formulation. And this I have to say. The kinetics of release. Almost all the single polymers have shown Oguchi diffusion model. The kinetics, Oguchi diffusion model. But the polymer blends have shown zero order kinetics. Means the time, if you plot the time against the amount released, then you obtain a straight line, and this of course is advantageous in case of sustained release formulation, because you obtain constant release all the time because of the time. So the blends, so the release follows the zero order, as you see the underlying number here, correlation and square correlation, especially for the least square analysis. Okay. This is the conclusion. Increasing the polymer drug ratio has shown good drug release in all circumstances. The table formula containing drug 1 to 3. One thing, but hydroxypropyl methyl cellulose, single polymer, gives the most sustaining effect among hydroxyl polymer. The table formula containing drug reject SPM. Okay, also this hydroxyl polymer doesn't affect the release enormously. The maximum is 5 hours in hydroxyl polymer. And then the polymer blends have given very good results, reaching to 12 hours. And the kinetics, of course. So, additional super, we have noticed that we added super disintegrant for some formula, the factorial formula, and to go through this study with disintegrable sustained release technique. We make it to do it like a multi-unit sustained release formulation by disintegrating the matrix step to avoid failure of release and at the same time to give smooth curve if the drug is given orally and you measure the plasma concentration. We have always noticed that the smoothness of the curve due to the multi-unit expression of the from the stomach to the intestine. Okay? This is the acetylbenzene. Give me just a second. Acetylbenzene, okay? And this is the faculty of pharmacy, acetylbenzene. Another blog for the faculty of pharmacy, acetylbenzene. Thank you.
Many thanks, Dr. Said. It was a very interesting lecture. Any questions? We'll take only a couple of questions, excuse me, just because we are running behind the schedule. Yes?
Please, do you know if this drug has any action at serotonin 4 receptor, heteroreceptor GIT? If this drug has any action as agonist at heteroreceptor serotonin 4 and GIT?
Really, I'm not a pharmacologist, but this drug, the availability of the drug is very good. The drug is well absorbed from the intestine, and therefore it gives effect through dopamine receptor and increasing the concentration of acetylcholine through inhibiting cholinesterase. And even it can be used for anti-emetic because the drug exhibiting its effect through the nerves before the emesis takes place. So it is faster, but I don't know about the pharmacology more than this. I'm a technologist.
Thank you, Dr. Said. Of course, a patient on continuous treatment by this drug will get rapid gastric emptying and short transit time in the intestine.
Yeah.
So the drug will not stay a long time in the GIT.
Yes.
So I am concerned that if we slowing the release of the drug, the absorption will be greatly affected and the bioavailability will be greatly affected and we will lose the therapeutic effect of
Yes,
it.
of course. I understand. This is a good question. This is a prokinetic agent. We deal with disease cases in which the GIT is not acting normally. Okay, it is slow. So we are dealing with a disease state. We are recovering into normal pattern. So it's normal. We give the drug for a normal, if the drug will transform the slow, lazy intestine and stomach to a normal pattern. Therefore, there is no problem. Because the entire time normally, for example, the entire time of the stomach normally, after meal, for example, is 3 to 4 hours or something. I don't remember. But in the disease state for which the drug is given, the situation is not like this. It takes, for example, for a meal to pass from the stomach to the intestine, 5 or 6 hours. Then we give the drug to take it back to the normal situation. So the sustained release effect doesn't affect because you have normal pattern of hydrodynamics in the stomach and the intestine.
Though this drug is mainly used for GERD, gastroesophageal reflux disease. So the problem is in the lower esophageal sphincter, not in the stomach or the intestine. I suppose the stomach and the intestine are normal for those people. And giving these drugs will enhance the function and will be over-functioning.
So it is not over-functioning. It's to normal. Because if we make it over-functioning, then we give them another disease. Why? Cramps and something
yes,
like this.
These
But
are side
I
effects.
myself, from my reading,
These
that-
are side effects of this drug. Diarrhea, cramps.
Side effects?
Side effects for these drugs, yes.
yeah, therefore, we put a disintegrant in order to avoid the side effects.
Okay, I'm
Because to deliver the drug stepwise, gradually, from the stomach to the intestine.
I'm concerned that we cannot get enough absorption of the drug.
The drug bioavailability is about 95%.
I think a next step in this study, we need in vivo study to
Yeah.
prove that it is applicable and there is good amount to be absorbed
Yes,
to
it
get
is,
the
it is planned to make a bioavailability study.
Oh, thank you so much, Dr. Sayed, and I'm sure Dr. Sayed will be happy to take any questions after the session. Thank you so much. We're actually behind the schedule. For this reason, we cut it short on the questions. Let's welcome our second speaker for this day, Dr. Anas Bahnasi, who has interest in pharmaceutical sciences research in general, in specific about pharmacokinetics and the clinical study and drug stability. He currently serves as assistant professor at Al-Isra University, Amman, Jordan. Previously, he worked as assistant professor at Midwestern University in Massachusetts, USA, and obtained his PhD degree in pharmaceutical sciences from Mass College of Pharmacy, Massachusetts, USA. Let's welcome our speakers, and you may start. Thank you.
Good morning, everyone. It's actually great to be here, and it's quite a great coincidence, actually, to have my presentation right after Dr. Syed's presentation, which is about the same theme of work. We basically, this work has been done over a year ago, and has been done at Copy Pharmaceuticals in South Boston, and we were trying to try a new granulation method that's related more to foam granulation rather than the regular technique of wet granulation. Our outline will go as usual for the purpose, the rationale, the methodology, as well as discussion and conclusion. Let's first start, why are we doing this? It's as easy as we are trying to provide a dosage form that's as bioavailable as possible, and we're trying to pick a medication that basically has more of a dual site of action. So the use of fluconazole, as we go through, was quite for that point. Oral dissolving tablets serve as this dual site of action dosage form. It can have a localized buccal activity, as well as it can have the central systemic activity as well. As for the granulation, I know that Dr. Said was trying to do dry compression. I was going to say that granulation basically is one of the most basic unit operations in making dosage forms. And what we're going to discuss now is a new technology that was presented in the AAPS meeting like 4 or 5 years ago. And they were talking about providing a better way of having, spraying in foam way the granulating fluid. What are the advantages of using this? It's basically trying to have an evenly uniformed, quite distributed mattress or a possible granulating fluid that will help in that manner. Why fluconazole? Fluconazole is well known as a broad spectrum antifungal agent that can be used locally, also can be used systematically, and that's why an ODT dosage form will provide that dual activity that we are looking for. As for the methodologies, in order for us to have a foam granulations, we need to have a special double-jacketed granulator. This was equipped by Joe Pharmaceuticals, the inventor of that granulator. After that, we picked the dose of 150 milligrams, put in a tablet of a size of 300 milligrams, which is the normal dose for fluconazole, and we tried to make the granulator uniform in size by using the milling at 800 RPM. This is the different compositions of the granules made by different composition of excipients, and as we can see, we try to have the excipients according to their hydrophobicity or hydrophilicity or hygrophobicity as well. So we can see that the picking was either totally hydrophobic, like using sodium lauryl sulfate and CMS in formulation number 1, to go to more in formula number 3, to more strictly like to be hydrophobic, and that's provide the hydrophobic form of that. As for processing of the granules were dried and then they were milled, as I mentioned before. We used lubricants and glidants, and the glidants and the lubricants pick was according to their hydrophilicity as well. And then the compress was at 4 RPM. Our results actually, let me just go back a little bit talking about the granulating fluid that we use in foam granulation. It's basically a mix of HPMC that dissolved in water with different percentages of urea that is provided at different levels. We try to have the granulating fluid at certain level, which is around 30 to 40% of the total formula. And we have noticed that the level of the urea has actually provided different levels of foam when we use that double-jacketed granulator. As for foam granulation, it can easily be scaled up as it's provided earlier by previous literature, and this actually can be applied industrially on the industrial level, and that's what we was trying to do at Coffee Pharmaceutical. As for the granules characteristics, we can see that most granules were accepted. Well, apparently all of them are within range of acceptable granules. As for the final tablet, we've noticed that weight variation was mostly within F2 and F3, and that's basically, we attribute it to the level of urea, and our explanation was that urea could have possibly and mannitol as well, they could have either crystallized or they could have actually have lost a certain level, leaving up some voids and some vacuums, could have that affected the weight variation on those tablets. As for the tensile strength, we've noticed that tensile strength was also different according to the mannitol and the urea as well, so we took this into consideration. Regarding the drug content, we found that the drug content was within range, and the in vitro disintegration time was mostly acceptable except for some of the modification that we can do for formula number 1 related to its hydrophilic excipients used. The final inspection of the tablets, we've had some visual inspection that showed acceptable level of tablets look and acceptable physical properties. As I said, the weight variation could be different, either because of high level of mannitol in comparison to the MCC, or it's related as well, the tensile as well, for the glidants, depending on if you use the glidant or the lubricant, whether it was used as more of a hydrophilic one or hydrophobic one. We used the USB accepted method of validation. As a industrial site, we try to more be strict to the basics in trying to have analytical studies. We found that this analysis was acceptable and was validated to have an RSD of 0.12 and a correlation coefficient that's very well accepted as well in comparison to any narrative. As for the accelerated stability study, we followed the International Conference of Harmonization. We tried to make some changes regarding the timing of sampling, and that was actually due to time frames that we had. So we had more sometimes shortened stability study of 6 months. as well as we didn't have a 1 month period of frequency, we had it all around 2 week time. The results, we had acceptable stability for the tablets prepared. The degradation followed the first order process. Degradation rate constants were determined. We used extrapolation using Arrhenius equation to find out certain parameters at different conditions. We found that formula number 3, we had 2 different kind of packaging actually, and we found that the packing in glass have actually a superior stability in comparison to blister packing. Statistical studies was done according to that, and we believe that the PFBC blisters could have problems with moisture, and that's why that could affect the stability of the final product. So we come to conclusion that the fluconazole stored in glass bottle had a superior stability, tablet characteristics by hydrophilic surface due to hydrophilic lubricant and hydrophilic ligand core that was related to high presence of urea and high presence actually of MCC as well. As for the porosity, we found that as well has a higher porosity, and we, as I mentioned that before, we kind of attributed that to the sublimation of urea at high stress conditions. The loss of drying we can see was the least, and we expect that the loss of drying was the least because of using of hydrophobic excipients, and that basically reduced the amount of moisture that already was available in the tablet. So the statistics that we have done or using SPSS actually have kind of confirmed that the lubricants has a big effect on the loss of drying, as well as the increase in hydrophobicity, and the lubricant result is decreasing, and it will actually have a direct effect on the loss of drying as well. Use of hydrophobic material will lower the LLG result during the stability study. This principle can be used as another tool for future tablets and to enhance the overall physical stability of orally dissolving tablets. So our final conclusion found out that we have a certain level of more acceptability, we can accept more having foam, this new method, new technique in granulation, and providing actually a stable, maybe with better level of physical characteristics to prepare different tablets, and especially orally dissolving tablets. We would like for sure to have the permission of Coffee Pharmaceuticals to present this work at the one I was part of, and thank you for everything. If you need a copy or if you have any, as I see we have a lot of time constraints, so if you have any later questions that we need to discuss or anything that you want to let me know about, please feel free to email or tutor, whatever you like. It doesn't matter. And I'm happy to take your questions.
Thank you so much, Dr.
Time
Anas.
frame as promised? Within time frames? Okay, great.
Actually, we have time for like a few questions.
Oh, there are more than a few, I see. Here.
Thank you, Dr. Anas, for your presentation, but I didn't understand why did you choose fluconazole as a drug?
Well, fluconazole, we have previous studies of making fluconazole for more localized action. So as orally dissolving tablet, I can have the action. It's like, think of it like more nitroglycerin, for example. You can have it as at certain point of area, and you can have it with one route of administration or one site of action, or we can have it more of a systemic effect. And fluconazole kind of follow this criteria. So with fluconazole, I can have for certain fungal infections, especially that ones that come after using antibiotics for certain people, like only sore mouth and sore lips. This will definitely help with that matter.
Hi, Dr. Anas. I saw that your stability table just your temperature is 4 centigrade. What
No, we actually had two different, but the ones that we are presenting today is the 40, but we had 40 and 50 degrees centigrade at 75% relative humidity.
Lower temperature.
You mean, what is it, how we calculated the K20? The K20?
No, this is the test for the high temperatures.
Yeah.
Say over 40.
Yes.
And this is the less temperature before 20.
No, we had two temperatures actually. We had the 40 and the 50. And the 20 was actually tested in extrapolation using Ernest equation. So we had only two stress conditions at 75 relative humidity, and that was at 40 and 50. And that's, I think, pretty standard accelerated study test. And we had the K20 actually calculated by extrapolation.
Excuse me, I know this now is in the market because it's always it's a business.
Yeah.
3 times, right?
Mm-hmm.
Well, you already pack it in a glass. I don't know this is why you have to pack it in a glass. And this is already granulation, right?
I see. I totally agree with you. There's actually differences because, as you can see, different markets is packaged differently. And we have the one dose fluconazole now. And even we have one dose, one time only. And that's basically very well done for certain, I think, women's infections, certain level of infection. However, what we are trying here is we're using the 150 milligrams, not just for blister packing. We just want to see our technique, which has the best stability for it. I know that what's available right now is regular tablets, the gold compressed tablets, and that's probably they did the studies for the blister packing, and that was fine. But in order for our composition, for our kind of mix of excipients, we found that glass would be probably a better packaging material, and we were relating that to, as I said, to more of moisture and humidity. We still have further work to be done, to tell the truth. As the speaker before me said, we will probably have to do some more in vivo studies. We have to see more of the release rate in vivo in certain sites, possibly in the buccal area, maybe more in the stomach area, in the intestinal area. So still much work to be done. But as I said, we did this packaging according to our new dosage form. It's not actually quite related to what's available in the market.
Let's take the last
Oh,
question.
sure.
It's very interesting to know about the foam granulation technique. This method
Yes.
is used during
Yes.
the preparation of your
Yeah.
granules. Am I obliged to use urea? Or maybe it has pharmacological effect or something?
Yes. That's actually a very interesting question. That's very interesting questions. And there are right now some studies actually to have more of a wide variety. There are other things that are tested. But what we did actually is we got more of what's recommended by Tolha Pharmaceuticals because the manufacturer of the granulator. And that's why we're, in this study in particular, we're trying to actually develop a new dosage form rather than just trying new things. You know what I mean? So basically we're trying to have a new dosage form that could be available in the market at one point in time soon. So we wanted to actually more of limit the number of variables that we have rather than increase our variables. But that's a great question. Maybe some others can be tried as more of a granulating fluid, and that could have a different effect for sure.
I expect you are using saponins or something to make foam during other than urea.
That's absolutely right. And we're trying to see, as I said, as you just mentioned, the compatibility of the whole formulation, maybe as well the therapeutic compatibility, maybe as well the physiochemical compatibility, all these things that need to be taken into consideration as well.
The second question, which is, you mean by fat disintegrated? Is the tablet going to disintegrate in the mouth?
Yes.
Or through the GI?
Well, we basically trying, as I said, we have further in vivo work to be done, but we were saying, yes, what we're trying to do is we can have a tablet that have a dual use. So one use can be just basically putting it in the buccal area, and it will be released fine. And as well, the same tablet can provide at least immediate action that could be available in the system as
Some
well.
of the drug will disintegrate in the mouth. What about the taste? Maybe it needs.
Oh, that's something you need to actually. to provide, and maybe sometimes actually we need to have some amino acid lipid like glycine that can improve the test as well, and supplement the urea that's possibly can be added to the granulator or can be added sweetener. We need to actually look further into this and look more into details.
Okay, thank you very much.
Thanks for your question.
Thank you, Dr. Anas. Our third speaker, Dr. Bilal Saleh, with a master's degree in clinical pharmacy. He will keep talking about the same track about tablets and capsules, but this time about the volume of water taken by patients. So please welcome Dr. Bilal Saleh from Al-Najah University.
Okay. Good morning there. Thanks for joining me today. Today I would like to talk about my study in Palestine. Really, it was rare and not so much discussed in literature topic. We are talking about the volume of water that used by adult patients when taking their oral solid dosage forms, tablets or capsules. I think it's a good idea to split my presentation into two sections. Section 1 will be an introduction to illustrate the importance of the study, and section 2 will be the study itself, trying to focus on its results, on its conclusions, and what are our recommendations. Okay, basically, as we know, the correct use of medications usually aims to support therapy success, which will further maximize the clinical response and the subsequent therapeutic outcomes. And it also will reduce the adverse effects. I mean the adverse effects in terms of their severity and number, both of them. So almost always we are focusing all the time to decrease these adverse effects and to increase the clinical response. So we support this balance usually. And this is a significant step in what's called the rational use of medicine. The rational use of medicine, trying to rationalize the use of medicine and to decrease the irrational use of medication. Usually, oral solid dosage forms, we are talking about tablets and capsules that remain in esophagus, they reduce the therapeutic outcomes of medication. This is not the only disadvantage. Also, many medications, they may lead to what's called drug-induced esophagitis. Drug-induced esophagitis. Especially when we are talking about highly or extremely harmful agents such as non-steroidal anti-inflammatory drugs, bisphosphonate, alendronate, and etc. Okay, tablets or capsules or oral solid dosage form, they are commonly delayed in their passage through esophagus. And unfortunately, when they do stick to the esophagus, they cannot be easily removed by drinking further amount of water or eating more food. Okay? And patients who take small amount of water with their medication, they will be at higher risk really from GI disturbances, especially esophagitis, especially or specifically when we are talking about chronic diseases. Chronic diseases means long-term medication. Also when we are talking about highly or extremely GI irritant medications such as bisphosphonate. Nowadays, there are about tens or around 100 medications that have been reported to induce esophagitis. We are talking about several groups of drugs. Let's see the most important of them. Bisphosphonates such as alendronate. We have also antibiotics such as tetracyclines, clindamycin, rifampicin, also non-steroidal anti-inflammatory drugs, especially aspirin, naproxen, and other agents. Also, we have oral corticosteroids, prednisolone, and potassium chloride is very irritant to the esophagus. Ferrous sulfate, quinidine as antiarrhythmic agent. Calcium blockers, especially nifedipine, sildenafil, theophylline, and vitamin C, and many others. All of them, they have been reported to induce esophagitis. Now, as a prophylactic procedure, prevention of these medications requires a reappraisal of the drug's indication and adherence to guidelines of optimal drug intake. This usually includes ingestion of the medication in an upright position, or at least inclined position, as shown in the figure, 45-degree inclined position, and to swallow with enough water. After some literature review in certain published studies, to achieve a high passage rate through the esophagus for oral solid dosage form, patients should, these are minimum criteria, drink a minimum of 60 ml of water or liquid, and